I'm just going to recap for those of you who perhaps weren't here for Alistair Miller's talk a couple of weeks ago about what fatigue and CFSME are, just for those of you who didn't have the chance to hear Alistair's talk. I'm going to move on then to talk about my particular area of research interest, the autonomic nervous system, and then Jason's going to talk about his area of expertise, which is sleep medicine and the relationship between sleep and fatigue. And then hopefully throughout all of that we'll talk about the research that's going on in Newcastle and the northeast of England. So just to remind you about CFSME, for those of you that perhaps are not aware, this is a condition that is classified by the World Health Organization as a neurological disorder. It's medically unexplained, i.e. we don't have a known cause at the present time for this condition, and as a consequence there are no biological-based diagnostic tests. But we do know that it is physiologically distinct from depression, and there are emerging scientific evidence to support that it is underpinned by immunological, neurological and endocrine abnormalities. So to diagnose CFSME, for those of you that are not familiar with this condition, patients present, for example, to my clinic in Newcastle, having experienced debilitating fatigue for longer than 4 months. We usually have to set about excluding other fatigue-associated conditions and other psychiatric problems that may be comorbid with the condition that they're describing. Generally, people have a very typical history, i.e. it generally occurs after a precipitant, and on examination there are no biological markers towards alternative diagnoses, and generally people's blood tests are normal. What is fatigue? For those of you that haven't experienced this symptom, it's very different than the symptom of tiredness. If you meet somebody who is experiencing fatigue or has a diagnosis of CFSME, you'll understand that this is something that dramatically impacts upon people's quality of life. In addition to CFSME, it's becoming clear that there are an increasing number of chronic diseases where fatigue is a significant symptom experienced by patients. And as a consequence, our understanding of fatigue and CFSME is slowly improving. And this is just to show you some of the different conditions that we in Newcastle are beginning to pull together into what we now call our Newcastle Fatigue Research Centre. And this is a recognised university research centre. It brings together clinicians and researchers who are interested in the symptom of fatigue. And all the blobs around the outside show you fatigue-associated conditions where we have quantified fatigue and are beginning to understand the underlying physiology that leads to this symptom. It's quite interesting when clinicians look at this diagram, because some of them only recognise for the first time that fatigue may be something that their patients describe. And often people will go away from a talk and actually begin to ask their patients about the symptoms they're experiencing for the first time. And the reason why we're pulling together all these different patient groups to help us understand fatigue across the spectrum of the fatigue-associated diseases is illustrated in this diagram here. And what this is a piece of work that we carried out in Newcastle a few years ago, where we asked a whole range of different fatigue-associated patient groups to complete a questionnaire about the symptoms that they were experiencing. And in doing so, what we were able to show was that the experience of fatigue in patients with ME is very similar to the experience of patients with, for example, stroke disease, or Parkinson's disease, or multiple sclerosis, all diseases where fatigue is very well recognised. And what that does for us as researchers and clinicians is emphasise the fact that if we can learn things about fatigue in one disease, then we may be able to apply that knowledge to other fatigue-associated diseases and hopefully fast-track our understanding from one disease into another condition. So what about epidemiology, how common CFS is? Well, you can see here it's actually quite a common condition. So most GP practices in the UK will have about 40 patients with a diagnosis of ME, which equates to about an annual prevalence of 4,000 cases per million population. But fatigue in its very broader sense, so not that constellation of symptoms that come together as CFS-ME, fatigue in its broader sense is the commonest reason why people go to see their GP in the UK. It's the main reason for consulting your GP in 6.5% of consultations. And UK surveys show that over 10% of adults have had substantial fatigue for over a month. So it's a massive problem for individuals, but also for our healthcare system. And in terms of the cost of that symptom, here are some figures from the United States. Unfortunately, we don't currently have equivalent data from the UK, but fatigue costs employers a significant amount of money. And if fatigue is present in association with a chronic disease, that trebles the cost of that condition in terms of lost productivity. So usually at this point, I take a step back and we deal with the elephant in the room. And for many of you who are here who perhaps have never met somebody with fatigue or CFS-ME, you will be having thoughts about, isn't this just malingering? Or are these patients not just people who want to increase their opportunity to gain benefits, etc.? And believe you me, I've heard all of those things before. But what I want to emphasise to you is that being medically unexplained doesn't mean that there is not a medical reason for why people feel the way they feel with fatigue or CFS-ME. Patients who experience this symptom and have a diagnosis such as CFS-ME, it destroys their lives. And I personally think there is probably very little for an individual to gain from having a diagnosis of ME/CFS. And it's very difficult to conceive that there is any benefit for an individual or a family by having this label of CFS-ME. So in terms of it being a real illness, and moving from being medically unexplained to being explained, well, the literature is beginning to give us some pointers towards what the scientific underpinning might be for fatigue and CFS-ME. Many patients do experience psychiatric symptoms, anger, frustration, anxiety, depression, but it's quite clear that this is a secondary consequence of the situation that individuals find themselves in. Wouldn't all of us be angry, frustrated, or depressed if our lives were destroyed by symptoms such as fatigue? So in terms of what the literature is telling us at the moment, what we believe is that an individual has a genetic predisposition to experiencing ME/CFS, that they have a specific thing happen in their lives at a particular time, and there's a triggering event, perhaps an infection, that leads to a cascade of physiological abnormalities. There's very good evidence that there's a dysfunctional immunological cascade that occurs, that they have problems with their HPA axis, hypothalamic pituitary axis, that they have problems with their autonomic nervous system, which I'll talk about in a little more detail. And there's a strong suggestion that there may be a mitochondrial abnormality. So what's the autonomic nervous system? Well, if you imagine that there is a vascular system within your body, your autonomic nervous system is the nervous system that controls that outside your conscious control. So we have our heart at the centre of that system, and our brain is at the top, with our legs at the bottom. And when I stand up, 700 mils of blood drops into my legs. But physiologically, I'm geared to keep my brain perfused with blood. So everything is designed to ensure that those bits of my brain that keep me awake are perfused. if my autonomic nervous system, when I stand up, doesn't get the blood back to my head as fast as it needs to, then at the extreme end of things, I may black out. At the subtle end of things, I may get very dizzy when I stand up and lightheaded. And at the really very subtle end of things, what we believe is that if there's not enough blood going to your heart, your brain, or your muscles, that manifests as the symptom of fatigue. And if there's an imbalance between these mechanisms, we believe that an abnormal response of your autonomic nervous system underpins these abnormalities, and as a consequence, it's called dysautonomia, so a problem of your autonomic nervous system. And we have very simple tools that allow us to quantify symptoms that people experience as a consequence of dysautonomia. So a problem of this response of your autonomic nervous system not coping quickly enough with changes in that vascular system. So we can quantify using something called the orthostatic grading scale. And you can see on this graph here lots of splodges which illustrate individual scores on this tool. And along the bottom, different conditions that are fatigue associated, with ME in the very first column, and the second column is a group of normal controls. If we quantify with this tool, and we use this now regularly in the clinic in Newcastle, you can see there's a wide spread of different scores. And a score of 4 or above is in keeping with problems with your autonomic nervous system. When we put all that together, nearly 90% of patients with ME, CFS, will have scores consistent with dysautonomia. And in fatigue-associated diseases like fatty liver disease and autoimmune diseases, varying amounts, proportions will have this dysautonomia. And in every condition that we've studied to date, we found that the more fatigued patients are, the higher scores they will have on the orthostatic grading scale, so the more autonomic dysfunction or dysautonomia they will have. And that led us to suggest a number of years ago that there was a particular type of fatigue, which we call dysautonomia-associated fatigue, that a significant proportion of patients with CFS-ME fell into that category. And then if you considered patients with chronic disease, a proportion of them would have fatigue, and within that group, a proportion which varied according to your chronic disease would have dysautonomia. So if we then believe that patients with fatigue have symptoms of autonomic dysfunction, what about objective abnormalities of the autonomic nervous system? Well, if we're thinking about measuring how that cardiovascular system is working, one of the simplest things to do is measure the head of steam that gets the blood round your body, the blood pressure. And we can do that by measuring blood pressure over 24 hours using a device that patients just wear in their own home, and then it gives us a measurement of their mean blood pressure over 24 hours. You can see from the graph on the left-hand side where this is 100 patients with CFS-ME compared to 100 patients who are matched for age, sex, BMI and for activity levels, that the head of steam, the blood pressure in CFS-ME patients is significantly lower compared to their matched controls. And the same is true in patients with fatigue-associated diseases, so on the right-hand side. So not only were we able to show that patients have symptoms of dysautonomia, problems with their autonomic nervous system, but we were able to measure that the head of steam, objective abnormalities, were also a problem in patients with fatigue. I put this slide up, just one slide to illustrate nearly a decade of my research life. But what this slide shows is that we can measure autonomic function using a range of different techniques, This particular one is something called heart rate variability. And when we do that in CFSME and in fatigue-associated diseases, we're able to show that fatigued patients have changes in their autonomic nervous system when we compare them to non-fatigued or control patients. So more evidence to support the role of autonomic dysfunction in at least some patients with the symptom of fatigue. So what does that mean to a patient who I might see in clinic with fatigue or CFS? Well, this looks like an instrument of torture, but actually it's a clinical tool that we use in my clinic, in my blackout clinic, my syncope clinic. It's called a tilt table, and it looks like a bed when it's flat, but it allows us to mechanically bring somebody to standing on the platform at the bottom so that we can measure their response to standing and how their autonomic nervous system copes with that stress of standing. So it's a physiological test. And when we've done that in patients with CFSME compared their results to controls, so we've had 64 patients who very kindly volunteered to have a tilt table test and compared them to, again, matched controls. What I want to illustrate with this table are the bold marks. So significantly more patients had a positive tilt table test, so have problems with maintaining their blood pressure during the stress of standing. And at the very bottom is a condition called positional tachycardia syndrome, where significantly more patients with the diagnosis of CFSME were found to have this recognised form of dysautonomia where they increase their heart rate when they stand up. And now we've replicated that finding in 3 series of patients with ME, and an Australian group have also shown that, confirming that about a third of patients with CFSME actually have this condition, positional tachycardia syndrome. So a quick whistle-stop tour through some of the research that we've been doing in Newcastle that involves MRI scanning. We've been looking at upstream abnormalities of the autonomic nervous system by imaging the brain using MRI and looking at how blood flow changes in the brain when we drop people's blood pressure. So patients with CFSME frequently describe problems with memory and concentration. And when we've quantified that, so the figure just here, using formal neuropsychometric testing, we've been able to show that patients do perform worse on tests of memory and concentration. When we've looked at their blood flow into their brain when we're stressing their autonomic nervous system, the severity of those blood flow changes, the figure just to the side with the straight line graph, the changes in blood flow associate with how patients perform on memory tests, suggesting there may be a relationship between the two. We've also been looking at muscle MRI by asking people to exercise while we've been measuring how much acid accumulates in their muscles. And when we've done that in patients with CFSME and fatigue-associated diseases, we've been able to show that they accumulate enormous amounts of acid in their muscle when they exercise and have difficulty getting rid of exercise at the end of get rid of acid at the end of exercise, sorry. And when we quantify that, they expose their muscle in their legs to about 20 times more acid compared to matched controls. We've been taking muscle biopsies from the patients who've been exercising the MRI scanner and been growing those muscle cells in the laboratory. And we've developed a system whereby we can actually exercise those little muscle cells in the laboratory so that we can get away from any volitional aspects of participating in an exercise-based study. and we can use our little exercise gym by putting cells into the wells of the little plastic tray over there and exercising the muscle cells to known amounts of exercise. And that has advantages for us because it means that we can begin to test drugs in that system to see whether we can replicate the acid accumulation that we've seen on the MRI, and then see whether by putting drugs into that system we can actually influence how much acid is accumulating in the muscle cells. And these are some fluorescent nanosensors that we have developed that go into muscle cells, and we can see how they fluoresce as the muscle cells exercise. And then using a drug called dichloroacetate, we're able to show that acid accumulation is reversible, suggesting that it may be modifiable and ultimately allow us to develop treatments that will reverse the changes we've seen on the MRI scanning. And then a final series of experiments we've done has been looking at cardiac MRI. So with cardiac MRI, we're able to look at cardiac function and how much energy is used by the heart. The figure just on this side shows 20 patients with CFS-ME, and experts tell me that a value of less than 1.6 on this PCR-ATP ratio is consistent with a subclinical cardiomyopathy, and 1/3 of the patients that we assessed had values below 1.6. We've also been able to look at how the cardiac chambers function by putting magnetic beads over the images, which allows us to look at how much torsion there is in the left ventricle as it contracts, and we've been able to show that there are problems with how the ventricle contracts in patients with ME, CFS and other fatigue-associated diseases. So I hope I've convinced you so far, and bear in mind we're only halfway through so far, that in Newcastle we've been able to confirm that there are autonomic abnormalities in patients with CFS-ME. We're detecting brain, cardiac and muscle abnormalities, and we're finding very similar findings in fatigue-associated chronic diseases. So at the moment, I hope that you are convinced that CFS-ME is a chronic disabling disease. We think it's probably got a genetic trigger, a genetic background and triggered by infection. But fatigue is a very common problem out with the context of CFS-ME and affects a whole range of different patient groups with chronic disease. At the moment, we have no curative treatments, but research is rapidly advancing in terms of physiological abnormalities that may explain some of the symptoms experienced by these patients. From my perspective, it's very important to say thank you, and I'm very grateful to many of the charities who funded a large part of the work that we do in Newcastle. ME Research UK and Action for ME and the ME Association have all been extremely generous to us. And I've been lucky enough recently to have a grant from the Medical Research Council as well. So we're on to the main act now of Professor Ellis.
Thank you, Professor New. Firstly, I'd like to say thank you so much for the invitation. Specifically, thank you to Julia. I never say thank you to Julia enough. She brought me into this, so it's all her fault. I was quietly working in a sleep laboratory at night, and then she said, well, you know, there's a lot of people with ME who have got sleep problems, so deal with it. And that was the challenge she gave me. So I'm going to talk about the role of sleep in ME. And what we do know, and the reason why I'm going to talk about that is because 95% of people with ME will complain as a primary symptom of unrefreshing or non-restorative sleep. That gives us an opportunity not only to understand the mechanisms behind ME, but also maybe to focus some treatment. And that's what we're going to look at today. But before I go into that, I'm going to give you a bit of a Sleep 101. How many of you sleep? I would expect to see a few more hands than that. Sleep is a phenomenon we all do. But sleep is actually made up of two very distinct processes. These are known as process C and process S. So as you can see from process C, it creates a very nice wave throughout the day and night. That's known as the circadian system or the body clock. Now here's an interesting point. The human body clock is not set at 24 hours. We are actually aliens on this planet. The human body clock is set at approximately 24¼ hours. Yes, madam. Now, this creates a very significant issue because if our body clock and our world do not meet, we have to rely on external cues to regulate our internal mechanism. So to keep the body clock set to 24 hours, we use light, food, and exercise. Okay, they're the three components that keep your body clock at 24 hours. If all of those things are constant, fantastic. You'll have a nice waxing and waning over the day. The second process is called process S, the homeostatic drive. Now, how many of you eat? I'm asking really complex questions today. How many of you eat? Now, if I went out for breakfast with you and I made you eat an awful lot of food, would you be hungry at supper? Well, let's say I made you eat everything on the buffet. Everything. Would you be hungry at supper time? No. No, you would not. Food and sleep are very similar. When you wake up in the morning, your desire, your burning desire for food increases throughout the day until you do one thing. Oh, this is so good. Once you've eaten, the desire to eat is no longer there. But you'll start that desire again after you've had your breakfast to get you ready for lunch. Once you've eaten lunch, you have no more desire to eat until supper time. The same principle is exactly the same in terms of your sleep, but you only do it once. When you wake up in the morning, you begin your desire to go to bed. The drive to sleep grows and grows and grows. It reaches a point, and then you will sleep. Absolutely. That's what makes you more and more tired throughout the day. Now, I've picked a perfect time to talk to you because you've all eaten, I hope. It'd be very bad if you haven't had lunch. So you're all actually starting to feel a bit sleepy now, because around 4 o'clock in the afternoon is when we actually put our pajamas on. We actually start getting ready for bed. The homeostatic drive and the circadian rhythm get themselves into alignment. We start producing hormones which get us ready for bed. So at 4 o'clock, you're allowed to go to bed, okay? Those are the two things that regulate whether you are awake. Can you see my drawing underneath? Beautiful. I'm very good at drawing, I am. That person is not dead. Wake, sleep, wake, sleep. That is it. Now, the function of all sleep disorders comes down to a dysregulation in one of those two factors, okay? All sleep disorders, whether it's insomnia or sleep apnea, they are all down to dysregulation between the two factors. Okay. What does normal sleep look like? Now, we're going to talk about the healthy adult because I don't like children. So this is what we will generally see from anything above 2 years old. So how many of you get into bed? Oh, see, fantastic. So you'll get into bed. And that's, if we can see at the top there, that's called awake. It's a very scientific term to mean not asleep. So how many of you get into bed and you start to get that warm, cozy feeling? That nice, warm, feeling, yes? Well, that's your brain slowing down. That's your brain getting ready to go to sleep. And we call that stage 1. But you're not actually asleep at this point. The transition from stage 1, we then go into stage 2. Our brain waves become even slower and more spaced out. we hit the actual official onset of sleep at stage 2. So once I've seen you go into stage 2, I know you're asleep. You're harder to wake up. It's very easy to wake you up whilst you're in stage 1. I just prod you. I'd have to have at least 3 prods before I got you awake in stage 2, okay? And this is what we do in my lab at night. After you've had sufficient amounts of stage 2, you'll go into stages 3 and 4, collectively known as slow wave sleep. Slow wave sleep is very, very deep. You've probably heard it called deep sleep. Deep sleep is the only time the immune system is actively working at 100%. That's why it's very important for us to get sufficient amounts of slow wave sleep. If we don't get enough, when we've deprived people and animals of slow wave sleep, we see that they become very, very vulnerable to infection very quickly. Okay, so we go through a nice period of slow wave sleep, then we go back up into stage 2. So we go back into a lighter form of sleep. Now, why would we do that? Why would we go and get some lovely, refreshing sleep and then go into a light sleep? Well, what we actually believe is this is a throwback from our past. If you think about it, when we lived in caves, and some of us still do, I've got a very nice cave in Newcastle. It's very nice. I haven't got doors yet. But anyway, if you think about when we lived in caves, would it serve you to be in a very deep sleep throughout the whole night? What if the saber-toothed tiger came in? What if my mother comes? It makes sense for me to wake up every now and then, not fully awake, but just to scan the environment. Make sure it's safe, make sure it's secure, so I can go back to sleep. And that's what we do. We go down, then we go up. After we've had our stage 2 sleep, we hit REM, rapid eye movement sleep. This is the period whereby our memories get consolidated and we clear out the toxin in our brain. Unfortunately, we do acquire a lot of toxins in the brain at night, and we're trying to flush them out and clean them. So this is good restorative for the mind. So you need both slow wave sleep and REM in order to function. Okay? That's the bottom line. You'll carry on this right the way through the night, hopefully. If not, there's a problem. But that is what normal sleep looks like. Now, as I said before, about 90 to 95% of people with ME will have a predominant complaint of non-restorative or unrefreshing sleep. That says something might be going wrong here. That says something to me that there's something in here. Well, the first thing you do in terms of with this population, because I didn't understand this population, I didn't know this population until Julia dragged me into the 21st century, was we actually ask people, it's terribly scientific, you know, we actually ask people what their sleep is like. And so these are key findings from sleep diaries with 101 people with ME. Now, what we found is 90% of them were reporting unrefreshing sleep as a principal symptom, okay? They are confirming to what we see in all epidemiological studies. But what we can see is there's very high variability in their sleep. Some of them are reporting problems getting off to sleep, some are reporting problems staying asleep, some of them report problems getting up in the morning. Some people report not sleeping at all. So we can see that there's quite a lot of variability. There's no central sleep variable that we can say is a characteristic of ME. That leads me into a very interesting place. One of the things that we did look at, however, is napping. And of course, when people do have fatigue, what are they likely to do? They're likely to nap. Now, we found that 79.2% of people with ME in this sample napped during the day. Of those, the majority, so almost 90%, were napping in the afternoon. Now, herein lies a bit of a problem. If you have a nap in the afternoon, and think about the homeostatic drive, remember? It's only meant to have one cliff a day. Up, 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 down. What happens if you have a nap halfway through, or even later towards the end of the afternoon? Well, the drive for sleep is then lost. This may be contributing to the problem of poor sleep in this population. It may be a cause and it may be a consequence, but it is an area where we can look at intervention. If we ask our patients with ME if they have to nap early. Nap early before 4 p.m., before you're putting your pajamas on. That will protect from instigating a problem during the night. Okay, so that's our first area of intervention. So the next thing we do after we've asked people what they sleep like, well, we want to actually look at what their sleep looks like. You know, I introduced you to all of those stages of sleep. Well, we want to now look at what the stages of sleep actually look like in this population. Well, actually, there's been 32 studies to date on sleep in terms of the actual markers of sleep in patients with ME, but there is no consistent pattern. We can find no consistent pattern of abnormality. Now, what I've got here is I've added it all together. I did some simple sums. I did adding and dividing, which is very scientific. And I came up with all of these numbers. So these represent the 32 studies that we see that exist at this time. What we can see is the first one is called total sleep time. How much time are individuals with ME spending asleep? And then how efficient is their sleep? How much time are they spending asleep against how much time are they spending in bed but not asleep? The third variable talks about sleep latency. How long does it take you to get off to sleep at night? And then we have a lovely, lovely one called WASO, wake after sleep onset. How much time are you spending awake during the night after you've initially got off to sleep? Then we've got all our percentages. You can see percentage stage 1, 2, slow wave, REM, and wake. Number of awakenings. How many times do you actually awake every hour? That may look like a very big number. Doesn't it look like an enormous number? Do you know how many times you actually wake up every hour without any disease, disorder, a healthy lad like me? How many times do I wake up every hour? Go on, treat me. Look at me and think, you know, how many times does that guy wake up every hour, huh? Oh, give me more than that. Oh, all right then, exactly 10. Somebody's done more homework. We actually wake up 10 times every hour. But these are called arousals. We won't fully wake up. These are where we shift over. We go, poof. And sometimes it's not even on purpose. So these are known more as arousals rather than awakenings, but we can have up to 10 an hour. And then what we've got there is the last variable is called REM latency. How quickly do you go into REM? Why would we choose a variable like that? The reason that we choose how quickly somebody goes into REM is because it gives us an indication of mood disorder. People who go into REM very quickly tend to have, or just about to acquire, depression. So we want to always look at this variable to see if there's something that's going on there. All right, so that's what the that's what the data is from the 32 studies. What I've highlighted here in red is these are where we can see abnormalities. So against what we would see as the norms in a general population sample, they're having less sleep. That would make sense. We can see that their sleep efficiency is poorer. We can see they're getting a lot more wakes after sleep onset, a lot more stage 1 sleep, a lot more stage 2 sleep, reduced amounts of slow wave. Remember the immunological factors here. They're getting reduced slow wave. They're getting, interestingly, also getting too much slow wave. So it's actually across the board. Reduced amounts of REM, so they're reducing in their amounts of REM, lots of awake, and their REM latency actually does not indicate depression. What we would generally see for depression is anywhere around 45 minutes to 65 minutes is indicative of, or at least it's one main characteristic of major depressive disorder. This population are not depressed. okay? It's very important to note that. But one of the things that comes from this is there's no pattern, is there? You can see that there's red bits here and red bits there, here a bit, there a bit, everywhere a bit. What that leads me to suggest is that there are phenotypes. There are different groups. Sleep is different in different people with ME. ME is not one thing. It's probably made up of a lot of different symptoms. So, we got some very nice data from a Dutch group. Julia practically went there and got it. She scored it in Holland. And what they did is they gave us just a selection of their data, everyone that had come through within the last year, and we got 343 people who had undergone one night of a sleep study. So we've got their brainwave activity. We want to look at the stages of sleep. We want to look at all of those variables. We want to find out who these people are. Is it one problem, or are there 2 groups, 3 groups, 4 groups? The first thing that we have to do is try to get rid of people or exclude them if they've got another disease or illness. And what we found from this is that there are 2 other disorders here that you can see from somebody's sleep studies, and we're almost getting rid of a third of our population here on the basis that a significant number of them have what we would classify as a diagnosis of obstructive sleep apnea. On the other side of the coin, you've got 17 people who would have had a diagnosis of periodic limb movement disorder. Both of those things have been related to fatigue independently. So we want to exclude, we want to exclude that third of the population just so that we can see what's going on with our 239 that are left. So we acquired a particular technique called a cluster analysis, and it takes all of our sleep variables into and says which ones actually match, which ones cluster together, and are they discrete? Okay? So what this will tell us is how many discrete different sleep phenotypes there are in ME, but also what makes up those groups. Our final analysis on this came out with 4 very different phenotypes. So there are 4 different types of sleep in ME. You can see the distribution of those. We've got a very small group 1, group 2's 23%, group 3 is the big one. That's the interesting one, and group 4 makes up about 10% of your sample. Now, what we would classify, if I was doing my sleep medicine thing, if I was seeing a patient, I would classify these into 4 different characterizations. Group 1, which is your small 6%, we would classify that as sleep onset insomnia. These are people who are having trouble getting off to sleep at night. They can't get off to sleep. Group 2 appear to be sleeping quite normally, but they're still reporting unrefreshing pain. And that's what I'm going to talk about theoretically in a minute. That's the group I'm quite interested in. But group 3 also, they are sleeping a very long time. They're getting a lot of sleep, but still reporting it as unrefreshing. And group 4 is sleep maintenance insomnia. People who are having problems staying asleep. They wake up frequently during the night. So we can actually see that sleep problems are not one central characteristic in this population. Okay, this leads us to a more theoretical area. Now, what we know is that during the night, and I talked about stage 2, yeah? You all got stage 2. I didn't talk much about it, did I? Not really, because now I'm going to tell you all about it. It's fascinating. Stage 2 sleep, we believe, is part of consolidating memory. You're turning short-term memory, getting it ready to get turned into long-term memory when you're in REM. That's one of our beliefs. The other thing is, to keep that process going, when the environment still can be quite noisy, we need to protect our sleep. And so stage 2 sleep has protection mechanisms inside it. And what you can see here is this is known as a sleep spindle. You see in somebody's brain waves, you'll see a very, very quick jagged edge. We believe that is part of the turning short-term memory into long-term memory, getting it ready to go. But it's also a protective shield around it. So it's going to protect that memory. The second facet we see in stage 2 sleep, can everyone see that big vertex wave? The big K. It's called a, Julia said K complex today, I was so proud. It's a K complex. And what we believe the K complex does is it's another protective mechanism. Think about it this way. You're asleep and suddenly a bird starts chirping outside your window. Now, the human organism is going to want you to ignore the bird, correct? So what's it going to do? It's going to create something in the brain to say, sod the bird, go to sleep. No bird, sleep. That's known as a K complex, and it's protective of not only noises, but sensations. So if you've eaten a lot during the night, which you shouldn't eat at night, bad, but if you happen to have done, and you're digesting food, as soon as your body's starting to digest, you'll create more K complexes to say, don't focus on your belly, go to sleep. That's what it does. All right. So here's an experiment that we carried out in my lab, and what we've got here is pulses of noise. So we've played pulses of noises to people every 7 seconds when they're asleep. And this is some work by one of my PhDs, Rachel Sharman. And Rachel's been playing noises to them every 7 seconds, not enough to wake somebody up. So we're only playing them around 38 decibels. 40 is World Health Organization goals around waking people up. So we're playing noises during the night, and I want to see what it does to your protection. Are you protected? Are you protected at night, sir? Let's see what happens in a normal, healthy adult. What you can see here is you've got more spindles and K complexes. Every single pulse relates to a new spindle. So this is the protective mechanism in play. What's the other thing you notice? Are they getting smaller? We begin to attenuate. Just as when we move into somebody else's house and they've got an awful clock, and we're listening to it all night, the second night we don't listen to it anymore. We've attenuated. And that's what the biological process does. It can't sit there all night saying, yeah, just ignore the clock, ignore the clock, ignore the clock. Wouldn't you get bored? So it says, ignore the clock. And so we start to attenuate against the noise. And then it becomes part of our normal sleep pattern. That, by the way, was a lightning storm. See, I play all the best noises. I wanted to play noises that, we would generally hear in the real world. Not, me shouting or anything like that, because I never shout. Okay. Now, what happens here? You've got exactly the same pulses. And what you can see here is the individual has attempted to attenuate, haven't they? You can see the spindle, the K complex, the spindle, and then an arousal. This person has failed to attenuate. So what they're doing is they're having an arousal. They may not wake up, but they're increasing the number of arousals that they're getting at night, which is going to directly feed into fatigue during the day. Indeed, in these individuals, and these were individuals who are prone to insomnia, what you can see is those people report significantly more fatigue during the day. And we believe that that may well be the case. So the next port of call for us in our examination of sleep in ME is to start looking at sleep instability, this cortical sleep instability in people with ME. It's been demonstrated in patients with fibromyalgia, cancer, and chronic pain. They're very pain-related disorders, but it is likely to also be there in ME patients. So that's where we're headed next. And as with all scientists, we have to create a model. I mean, our lives are meaningless unless we have a model with lots of boxes in it. So we have, and this is Zoe Gotts, who is Julia and I, it was our PhD student who's now gone on to soar the world science stage with her work on ME. And Zoe's actually put together some work of Julia's and some work of mine to try to create a complex understanding of sleep and its relationship to fatigue in patients with ME. So that's where we're actually focusing now. And that's where I'm going to leave it. I always like to thank everybody, so everyone who does all the work, because I don't do any work at all. I just float around and chat about it. People actually give me money. I know it's outrageous, but I'll take it. Don't say anything about Transport for London. Thank you.